Hi everyone, my name is Steve McGloughlin. I'm Director of the Alfred Intensive Care Unit in Melbourne and Executive Director of the National COVID Clinical Evidence Taskforce. And I've been asked to talk today about the development of COVID therapeutics. So thanks for coming along to the talk today. What I'm going to talk about today is a little bit about why we need treatment for COVID-19, where we've come from over the last 2 years, which has been quite an exciting journey and quite challenging, obviously. And I am going to talk about the treatment guidelines I'm involved in Australia, really just as a representation of what is available for treatment guidelines and maybe what we should be aiming for in the future for these rapidly changing and evolving situations. What are your current options for treatment and where you can go to find out more information and what might happen next. As I said on the previous slide, I do have to declare a conflict of interest. I'm an Executive Director of the Clinical Evidence Taskforce in Australia. The Taskforce, I'll talk a bit more later, but it's a not-for-profit government-funded agency aimed to help clinicians in Australia and anywhere in the world with advice to COVID-19 treatments. I'm also fortunate to work at the Alfred Hospital in Melbourne, which is Australia's largest intensive care unit and was affected significantly by the COVID-19 pandemic, although I don't think anywhere in the world was able to avoid that. So why do we need treatment for COVID? Well, I don't need to belabor this point, I guess, but this is the slide we look at our work all the time. And so we're up to 525 million cases with over 6 million deaths. Obviously, there's a good understanding that deaths may be an underrepresentation based on reporting from around the world, especially in resource-poor areas. And, 1,700 deaths on the day that I looked this up. And you can see the areas that have been more affected, I guess, based on the concentration of numbers of deaths. But really, as you'll see, the main thing I'll notice now from this graph is really nowhere has there been able to avoid the impact of COVID-19. And still we're seeing in Australia, the number of deaths, are between say 30 and 70 a day, which, as a number obviously is significant. And when you look at that over a year, it's still one of the major causes of death in Australia at the moment. And even more distressing, it obviously affects the most vulnerable members of our community the most. So this all started in early 2020. This is a slide from my ICU in Melbourne, where we're obviously a mechanical ventilation and ECMO centre. And in early 2020, it was really just a test of the healthcare system able to support people. So we had very limited treatment options available, if any. There were some trials that were starting to be commenced in early 2020, and we were really providing on supportive care and relying on the fact, our history with other viruses such as influenza and that if we supported patients long enough, then they would get better. But we didn't really have a way, which has changed a lot, of someone in the community saying to them, we have a way of reducing your chance of getting very sick and needing hospitalisation or of needing critical care later on. What we tried to do was try and offer some supportive care to allow people to get through this. And many patients did, but obviously this is an era of pre-vaccination as well. So we saw a lot of patients in critical care from around the world, including a lot of disturbing footage. During 2020, dexamethasone appeared as a treatment option. So, ironically, one of the oldest drugs going around, I guess, in the critical care, dexamethasone, is sort of almost a bit of a joke in intensive care because steroids are something that we've always tried. We've always thought there might be a place for steroids in critically ill patients, and could they really help someone to survive or get out of intensive care faster? And the evidence, as most people will know, was conflicting around steroids for most treatments in intensive care. There was often a little bit of evidence that steroids would drive patients towards recovery faster. So whether that was from ventilation or from needing inotropes such as adrenaline, but there had never really been a lot of evidence to show that it helped patients to survive. But over 2020, through some preprint publications and then some published data, we were able to see that dexamethasone did have an impact on survival for patients in intensive care. And this was I remember when this was started as a treatment in Australia, because we just felt a great sense of relief that we're able to offer something for patients that might help. And we had some data available to support that. You can see that this is just interesting. The first slide I'm going to show you here, we'll talk about a couple of things and you'll see why I'm demonstrating this data in a minute. So this is in Australia. You'll see along the x-axis of these graphs is the day in ICU of cumulative number of patients. So not one patient, multiple patients in ICU. And you can see that how things changed over the course of the pandemic. So each coloured line is a different phase of the pandemic. In Australia, we sort of divide it into 3 phases, which is maybe a little bit artificial because we're probably in a 4th or 5th or 6th phase even now, depending on what you think. But the first phase was really that start of 2020. The second phase was the second half of 2020. And the third phase was the phase in 2021. And what you can see is interesting. I'm just going to draw your eye down to the one down in the middle there at the bottom, which is prone positioning. And you can see in the first 2 phases, there wasn't much prone positioning done. Only maybe in the first phase, almost no patients on the first week got prone positioning, but maybe they got prone by about the 7th day of their time in ICU. You can see the aqua line, by the 3rd phase, people were getting proning very early in their stay in ICU. And I'll come back to that about how the evidence shifted the treatment in COVID-19. You'll see some of the other graphs changed less so because there was less treatment available or less data available. Another one that might be just worth commenting on briefly, and this is Australian data. The graph on the top left, you'll see high flow nasal cannula oxygen. So you can see in the early phases, in the early phase 1, there was very little high flow nasal cannula used in intensive care. Whereas by phase 2 and phase 3, a lot more. So by phase 3, 60% of patients were getting high flow on their first day in intensive care. The reason that's important is that really showed an improved demonstration of infection control and fear around COVID-19, and probably the influence of vaccination for staff. So by phase 3 in Australia, most healthcare workers were vaccinated. But coming back to this one as an interesting point, I mentioned dexamethasone at the start, so I'd like to comment on this for this graph for you. So the same colours as was on that previous graph, if you have a look. And if you look along the x-axis this time, it's the percentage of patients admitted to ICU. So if you look at the top line, for example, invasive ventilation, you'll see that phase 1, about 60% of people got ventilated. In phase 2, about 50%. And about phase 3, about 50% as well. So no real change. But if I could just draw your eye down to the 4th line, which is steroids, you'll see in that first phase of ICU, about 20 to 30% of patients got steroids when they're in ICU. By the 3rd phase of COVID-19, so that's since 2021 in the Australian context, nearly 100% of patients received dexamethasone in ICU. And you can see on the next graph, the same thing happened with prone positioning as evidence became available. So you can see what was really amazing for in medicine, which usually moves relatively slowly. We're able to see the translation of evidence into treatment very quickly. You'll also see what's interesting is that the bottom one talks about antivirals, how that went from 0 to higher. Now, this is about antiviral therapy in ICU. So you would have noticed, and I might have some time to talk about it later, that antiviral therapy in critical ill patients probably has little part to play. It's really about treating the virus before it causes those problems. In terms of our treatment in Australia, the other thing, I guess, I just mentioned prone positioning, and I guess I wanted to talk about this briefly. I know it's a talk on therapeutics, but I guess it's worth saying that some of these things, you can see why evidence to support treatments is so important. So this is proning a patient in intensive care and how many people it takes. This was in 2020. So people were unvaccinated staff getting ready to prone a patient. So you'll see the number of people in the room. It happens relatively quickly. But obviously, if we're going to put the patient through this risk, we're going to allocate this many staff to a treatment. We want to make sure the evidence is supportive of what we're going to do. And over time, with things like proning, we've been able to demonstrate that importance. And that's also happened in drug treatments as well, where we've seen more and more drug treatments become effective, although, as I'll come back to, probably more so in the non-critical care environment. I'll just let the team do that, and then I'll move on to the next slide. So as we've moved on, and I'll come back to this a little bit at the end, we have a lot of time with, as these drugs have become available, we went from beggars to choosers, if you like. So early on in the COVID-19, we were desperate for any sort of treatment that might help patients. Now we have a number available, and so what should we do? So one thing the Taskforce has worked quite closely on is trying to come up with decision tools to help clinicians as to what treatment they're going to use. Now, I won't try and go through this slide during the talk. These are all available online for everyone to use. But it's just an example. If you think back to that first slide where I showed there was no treatments available, basically we had a black hole in the road for treatments for COVID-19. And now we have all these other options available. And what treatments should we be using for patients with COVID-19? And I'll come back to this in a little bit. And then the other part of the equation is, what do we do for patients? How at risk is the patient? So we've known with COVID-19, we've now added them into the mixed vaccination, which clearly has an effect on the risk for patients. Obviously, booster shots have added complexity even to the vaccination argument. In Australia, we're now in a population level trying to get 3 shots or 3 doses of vaccine and a 4th dose to people at risk. And who knows where this is going to take us into the future. So what we've tried to do here is try and look at people, well, what is your risk of developing COVID-19 that's severe and putting you in hospital or even something worse? So for myself, as a general population and someone who has had COVID recently, as a general population with no comorbidities and a vaccination up to date, and in my age, I won't tell you exactly my age, but it's just less than 50. I can see I'm in a green bar here. I'm a very low risk of getting disease. severe illness. So I don't need to think about having the antivirals, obviously looking after my health, etc. when I get, if I was unlucky enough to have COVID-19. You can see how that would change if I was unvaccinated. And if I started to develop, if I was unvaccinated with multiple comorbidities, even at my age, I would have significant concerns that I'd be at high risk of severe disease. So you can see how things change quite quickly. So I'm going to talk briefly about the task force, again, declaring that I'm an executive director of this organisation. So it's funded by the Commonwealth Government of Australia with very strict, obviously, adherence to conflict of interest and trying to provide national evidence-based guidelines for the clinical care of people with COVID-19. We were able to set up a situation where nearly all the major colleges in Australia are part of the team. So we have 34 stakeholders that are involved, and you'll see, if anyone's worked in Australia, you'll see the name of all the major colleges are involved and represented in that group. So hopefully most clinicians in Australia, their representative body is part of the Clinical Evidence Task Force and has to sign off then on the guidelines that we produce. So they're consensus-based guideline. So that means we aim for agreement, obviously, as a consensus-based guideline. This is just a cool snap we put together of all the clinicians involved. So many people will know, you look for yourself in that if you're in the Australian context, and we obviously go for a diverse range of clinicians from all over the country, not just medical, pharmacy, nursing, allied health, people with expertise, and people with time to dedicate to providing evidence-based guidelines. And so we have basically a turnaround period of about 2 to 3 weeks from evidence being published to evidence being produced in a guideline that can be accessible to clinicians. And I think now we're over 50 guidelines that have been published by the task force. And just in terms of context, we can say that we have obviously a very thorough process to developing and signing off these drugs. And I must admit, when I started in the task force, I was a bit confused as to why we needed to be so focused on task force governance and process to make sure we were correct. Because when we started the task force in 2020, there was really no drugs available. So it seemed a bit of overkill, really, to be talking about what at that point were just consensus-based guidelines on how to ventilate someone or how we'd recommend not using drugs unless they were in a clinical trial. But as drugs were developed and we saw the quality of trials that were being produced, and we saw complications that made things difficult, so preprint publications, or we saw virology studies that had no clinical context, we really need to make sure the governance is very clear as to what we can do for our evidence-based guidelines. So we've got a number of different panels, and I was obviously involved in the acute and critical care panel initially. And that was one of the busier panels early on, if you like, as we were trying to work out the appropriate treatments for patients with COVID-19. The purpose of this talk, obviously, we've moved more to a disease-modifying treatment and prophylaxis panel. I won't go through this too much, but you'll see that we're really looking for living guidelines. And I think that's something I'd encourage most people to, as clinicians, to really get involved in if you can. It's quite an exciting look at working in a guideline space. So you're really trying to produce guidelines that will change, be up to date, as I said, week by week. So I've got a few slides now that go through a lot of different treatments, and I can make these slides available. And also these are all available on our website for the task force. But I guess I just wanted to comment on how we've gone from nothing at the start to corticosteroids to now a number of different treatments. And one little thing I'm just going to talk about now is that the variants are really making an influence on things now. So most of the trials were done still in 2020 or 2021 that are published now, where the dominant variant around the world was Delta or maybe even pre-Delta. Omicron, obviously, everyone will remember in November, December last year, that the reports coming out of South Africa, and then this sort of explosion of Omicron around the world. And now the obvious subtypes of Omicron coming out as well. So we're now dealing with a situation where people have put a lot of effort into producing evidence-based trials, but there is a significant virological difference between the drugs, between the virus that is being studied in the trial and what's being treated now. So we've had to try and factor that in. At the task force level, we've introduced virologists to try and help us with that understanding, because obviously the in vitro data is not clinical data, but it's cognizant to remember that data as well. So we'll see here that we've got systemic corticosteroids for adults being recommended, and a drug called baricitinib as well for hospitalized patients. So on this table is patients that are requiring supplemental oxygen, I guess as a marker for being in hospital. There are some places around the world delivering oxygen out of hospital, but predominantly now that's obviously done in hospital. Another drug that was used a lot in Australia was Tacalesman. And this was something that I guess is not an antiviral drug, but it's thought to be an ability to reduce the systemic inflammation that's affecting our patients. Again, one of the earliest treatments that was recommended, so published in 25th of February 2021. So that's a long time ago now, or it feels like a long time ago. And obviously, as a clinician in intensive care, I definitely seen the effect of systemic inflammation on these patients well after the virus was thought to be no longer active, based on testing and based on our virology experts and what they were telling us. You'll also see the drug remdesivir, which comes up again, and now is not recommended in hospitalised patients based on data. So what's really taking a lot of interest in Australia now, and I'm sure it's the same all around the world, is the people before they come to hospital. So how do you pick patients that might deteriorate and then may need hospitalisation? And then because they need hospitalisation, obviously they're the group that are at risk of severe disease. So how do we pick when you've got thousands of people being diagnosed every day around the world, if not many tens of thousands? How do you get the right patients to get antivirals before in the recommended timeframe to reduce that risk of severe disease? We've got a number of drugs that are recommended in Australia at the moment. The drugs that I'll just talk about briefly in a second, drug called Paxlovid, which I have a lot of trouble pronouncing, so I won't even try. I don't like to use drug company names, but I do struggle to pronounce the real name of that drug. And you'll see down the bottom then, it's got a conditional recommendation to start within 5 days of symptoms onset for one or more risk factors for disease progression. And a consensus recommendation for at-risk unvaccinated adults with multiple risk factors. Consensus being something that's based on the expert's opinion, conditional obviously based on evidence base. And you'll see there's discussion about pregnant and child and adolescent as well. But how successful, how impressive is this drug? So if you go through our website, we try and produce these graphs for people. So you'll see, does it reduce hospitalisation? Well, the evidence would suggest that 55 fewer hospitalisations or death amongst 1,000 patients with Paxlovid. You'll see that the next table will give away that most of that is reducing hospitalisation, because you'll see the numbers the same, obviously. So the reduction in death is relatively low, but the risk of hospitalisation is significant. You'll see a small decrease, serious adverse events, there was less. So, which probably relates to the disease, obviously, as well. And you'll see down the bottom, we've got the certainty of the adherence, which is moderately certain. I'll talk a bit in a second about the challenges of the evidence we're facing, but I thought that's just an interesting way of looking at how we judge these drugs and what they can do. And I mentioned before about Tacalesman. So you can see the same thing. Actually, a mortality benefit of 39 for 1,000 patients, respiratory failure of 142 per 1,000 patients, but more adverse events, which is potentially not surprising in that group. But a low certainty evidence of the respiratory failure ARDS. Now I'm coming up to the end, so I might just leave that slide there for people to have a look at. And I'm coming back to this slide I mentioned before, just to remind people that now as we get more drugs, this is going to be the key factor moving forward, is how do we get the clinicians the right information at the right time so they can make the right decision as more and more drugs become available. As I mentioned before, we're not only trying to look at the severity of the illness for the patient, but also their risk of severe disease and what antivirals could help them. So I guess I see a number of challenges ahead. One is, as we get more treatments, one of the things we're really struggling is how do you prioritise these treatments? Which treatment should which patient get? There's no, as far as we know anyway, any head-to-head trials of any of these drugs. So I can't tell you that whether one of these antivirals is better than another. They're all independently run trials, and there's very little information coming through on that. There's also the impact of what governments and jurisdictions are doing in terms of buying these drugs and how they're being produced. And that's a talk for another day, but obviously that's really going to impact what a clinician can give a patient. And there's obviously going to be a little bit of variation in clinical practice, as it occurs with any treatment and drug that becomes more widespread in terms of the disease. And there will be new evidence emerging. And one thing, if I could just advocate, one thing we are struggling with in the treatment world is really a lack of evidence and real world data. So relatively small trials are being done on these drugs. They're being produced, published, high quality trials, but we're not really getting that in-depth follow-up data where we can look at things like the safety outcomes. What is the impact of these patients? How many patients did not go to hospital? Does it match up with what we thought with the trials? And we're hoping that data starts to come out from around the world, because that would really make a difference. One little thing from the Clinical Evidence Taskforce we have online, if you want to ask us any questions or thoughts, please let us know. We do look at all of them and we're happy to have a look, and you'll just see that on our website. And just to say thanks very much for your time today. Thank you.